I feel like I should take the glasses off.
You're totally good. Whatever you want. All right, we are officially live. It says done, redirecting to Facebook. All right, well, we're almost live.
we're trying to be live.
Yes. All right, and then let me turn this down. I have my phone in case people have questions that pop in. I can see it a lot easier while we're talking. So
okay.
Yeah, we just do this. All right. So one more moment. There we go. All right. Well, it is Thursday evening in the great Eastern time zone where we are broadcasting from. I'm Betsy Pilon, and I serve as the president of Hope for HIE, and I am live here with Nancy Calamusa from the New Jersey Pediatric Feeding Associates. And Nancy, it's so great to have you with us tonight, and you are a renowned pediatric feeding specialist, and we've talked several times over the past years. You have been a great support to so many HIE families in our community. And I'm really excited to have you with this Q&A tonight. So thank you. If you want to just, kind of talk about you and your expertise and just a little bit about the work that you do, just to kick us off.
Sure. First of all, thanks for having me tonight. Like you said, I am a huge supporter of the HIE community and your organization as well. It's near and dear to my heart. As many of my families, my current patients, previous patients, and hopefully future patients are part of your organization. A little bit of background about me. I've been in pediatric feeding and swallowing for over 30 years. Yep, 30. I can't believe it myself. But I've never, let me go back. I'm a speech pathologist by education. But I've never done speech pathology in terms of articulation and language. I've always done feeding and swallowing. My career started in New York City, to be honest with you, during the plague of crack cocaine. So I was kind of thrust into pediatric feeding and swallowing because there really wasn't many of us doing it. So I was lucky enough to have some of the best in the country as mentors, some physicians, some colleagues who were also speech pathologists at the doctorate level, who sort of took me under their wing and mentored me. When we were doing this type of therapy back then, doing any kind of feeding and swallowing, it was basically either in a NICU or at what we called a community center, which is like your earlier intervention that occurs now, except it wasn't in the home. We were all center-based. So it was much different. We had a lot more responsibility back then. We were able to work with feeding and swallowing within that center. And as my career changed in terms of location, so did my responsibilities. So as I met more and more physicians and neonatologists, I was sort of put in charge of developmental feeding intervention in the NICU. Since it was such a new area, meaning that there was another professional coming into the NICU to do this, it wasn't without its fights. As you know, sometimes it could be tumultuous with other professionals and very territorial. So getting them to understand what my skill set was, what I could bring to the table, how I could alleviate some of their burdens and their stresses of feeding some of these children, we slowly started to build relationships and get that camaraderie moving within the NICU. So I was fortunate enough to have some people with welcoming arms, others not so much, but that's just the nature of the beast. So I'm going to tell you a little bit about, as we were talking before we went live, why this is so near and dear, why I'm such a huge sort of advocate for all kids with feeding and swallowing issues, because not only on the professional side, but on the personal side, I guess it was about 5 years into my career, decided to start a family, and my son was born premature. He had a subdural hematoma. He was in the NICU, and see, it can make me very weepy right now, and he's 28 years old. But that being said, he was in there with an NG tube. He had, all of the best care going on. And here I am, the feeding and swallowing specialist, sitting at his bedside, like petrified, because I didn't know what to do at that point as the professional versus the mom. So I allowed the nurses to take over. And one day I was watching this nurse, and I was getting more and more frustrated and angry as I saw her sort of spinning the bottle, gouging the bottle, laying my son down, seeing my son not responding well to her methods. And I think at that moment was where I really became the advocate, not only for him, but sort of birthed my advocacy for all kids with feeding and swallowing issues, because I felt if I wasn't going to advocate for him, who was? And me being the professional, I had a better skill set. Let me take it over. Her response to this day is still here. And she said to me, "You can try, but these lazy feeders are what cause us the most headaches." And I thought, he's not a lazy feeder. He's a child who's convalescing. He's a child who is trying to get better from no fault of his own. And here you are labeling my child as this lazy feeder, or somebody who is more of a burden than somebody you wanted to help. So I think at that point, I sort of switched gears, and I literally became every NICU's worst nightmare, because there was one doctor who said, if you had steel tip boots, I could see you kicking in the doors of this NICU and swiping bottles out of everybody's hands, which was literally what my job was. Because when I saw them feeding these children in a maladaptive way, or coercing them or forcing them to feed to make their quote unquote MLs for that time period, it would drive me insane. So I did a lot of education. I did a lot of pairing with some of the medical schools in our area. We are close to Rutgers University, which has its own medical school now. It used to be Robert Woods Medical School, which is a big university hospital here. So they allowed me to start educating at the medical student level, which was great, because I was starting to get the teams of people that were ultimately going to be taking care of your kids at that vulnerable point in their career where they didn't know better. So they had somebody who was coming in and sort of pushing their cause or their issue. And I think, thankfully, a lot of them did listen to me, because it did make them better doctors when I saw them later on in the NICU. So that's how my career began. My son is 28 years old. As I said, he graduated from the University of Connecticut with honors, and he is now living in Connecticut. So it does get better. It can get better. He can eat, and we're thankful and grateful. So I guess that's all about me personally. I also have a daughter. She's 27. I went right back into the pool of delivering and having another baby right away. And she'll be graduating college the end of this year. So we're thankful and we're blessed and happy. But in terms of my career, unfortunately, as much as I love the NICU and my time there was fantastic and I learned so much and I helped so many of the families, I started to see in the NICU developmental follow-up clinics that a lot of my patients were coming back with either no feeding or swallowing therapy, or they were coming back for G tubes. And as I started to see this trend where a lot more of my children that were doing okay and just needed some support at home were coming back in worse shape than when they left, that's when I decided that I needed to do something more to support those babies sort of on the outpatient side. So rather than stay with the hospital, I opened my own clinic, which is now New Jersey Pediatric Feeding Associates. So 15 years ago, that was birthed, and I haven't looked back. I haven't looked back at all. It's been a great ride. We have helped thousands of infants and children from around the globe. We provide intensive feeding therapy from 1 week to 4 weeks, where we see the children 2 to 3 times a day. We're sort of activating that neuroplasticity that's so important, getting them to habituate into the correct patterns of feeding and swallowing, and trying to make it easier on the parents and just alleviate some burdens from all of my families.
Yeah, we talked a little bit earlier too about the families that are in the NICUs and how and you spoke about your own experience as well of like that critical like ML number and things like that just add to parent stress. And, um, so I guess what is some advice that you have for families of like how to advocate for, themselves and their children, whether they're, still in the NICU or, fresh out of the NICU, and whether they're sent home, on an NG or having feeding difficulties, like what is their, kind of next step or things that they should be asking?
And that's a good question. I think, relatively, we have to look at the NICU environment and where these children are being housed, these infants are being housed. So a lot of the NICUs are somewhat attached to some sort of learning university. They usually have attendings, and then they have their fellows and their medical students. So we have a variety of people coming in. And as your lecture from today stated, you're getting all of this misinformation or all misleading information from different people who aren't sort of conversing or meeting about your child and giving you the right directional path. So I think for people who are currently in the NICU, it's important, in fact, it's imperative that you have, or at least ask if you can have some sort of assistance or guidance from a feeding specialist. That can be an SLP, it could be an OT, in some hospitals, it's PTs, but get somebody in there that can help advocate for your child. You have enough stress to deal with and all of the medical issues. And although this is a medical issue in itself, you need that voice to sort of support you in moving forward and getting the children, the infants, to be able to get some oral exploration that they're not getting, and I feel like we look at these children, especially in the HIE community. I know from my own experience, they're like, no, these kids are very severe. You need to just let them rest or let them sort of convalesce, but we're losing critical time also. So if we get them sucking and swallowing, so many things can improve with just that, right? Your respiration improves, your digestion improves, your secretion management improves. So the quicker we can sort of get on that path, the better. So I think for our parents who are currently there, if you can request or advocate to have a feeding specialist there, and if they don't have one, ask them if there's a neonatologist or someone who you could speak with that can help you sort of pump the brakes and not worry about how much these children are getting per meal, but what the quality of the feeding is, not the quantity.
That is such a dynamic shift from what,
Right.
I think the typical experience is. We spoke just prior to this, and recalling the nurse that, and I think we all have these experices of that one nurse that just like you
the one who never leaves your head.
Yeah, exactly. That like as we talked about earlier, like the toothpaste, like you can't unsay it and you can't unhear it. But just remembering of like if he's slow to feed, if he doesn't get this in a certain period of time, we're gonna put an NG in him and gavage the rest, and it was just like real nasty and
like a threat.
Yeah,
like
absolutely. And like
right.
like panicked mom, in the NICU, and it's like you're already worried about all these other things, and what does this mean? My child, they told me it has a brain injury, and now we're worried about this, and it's like
right.
everyone.
Well, I think you're right.
Measuring, like.
I think that's also correct. It's the problem is, like we discussed, is that there's so much pressure. Mm-hmm. There's so much pressure. They're telling you that your child has had this event that is, could be catastrophic. And then there's all of a sudden you're now have to become this medical expert, either, by default. And when somebody is sort of telling you that, if you don't do X, Y, and Z, and it's going to result in this, and you don't even know what those things are. I'm sure at that point, you didn't even know what a tube meant or what gavage feeding meant at that point, right? So I think what bothers me the most is the threatening of, if they don't do X, this is going to be your terrible result. So you now look at this alternative feeding method, which may or may not be your child's future, as something is bad immediately. because it's been threatened. And that's the worst case scenario. And now you're heading that way. So I think that we have to sort of change the conversation. We have to make it where you're saying, listen, I understand. I get it. I know that my child has to feed. I understand that he has to do X amount of mLs within 30 minutes, and he's bradycardic, and he's tachypnic, and he's all of these things, but he's still my son, and I still need to advocate for him, and I still need to make sure that what is happening is quality of work, and not just so you can check a box saying that he got his 10 ml, his 30 ml, whatever it is. Right. And that's the problem. That's where, as much as I would love to say that things have changed in the last 30 years, they haven't. It's still the same scenario from back in my day of being in the NICU, where everybody is worried about how much they're getting and not how they're getting it.
Right, absolutely. Sorry, I think I'm just double checking that we still have the feed going. So
is it only me and you?
It might be just me and you. My phone, I hope people are still there. Let me double check that this is still going.
I can't believe it myself.
And I think this is still going, so that's good. Like the magical wheel on my phone just started spinning, and I'm like, all right. Let us know if you can still hear us, and if we're still. Oh yeah, there's actually some comments. Good. Okay, great. Okay. So we're still live. Let us know if you can still hear us out there by commenting in the thread. Oh, we're here. Okay, good.
All right, good. Hi, everybody.
My phone just started magically. You guys, I always have my, you can't tell because it's screen. But I always have my phone up here so I can like follow along on the same screen when we're doing these. And it just like magical wheeled and died. So good. So, but I have two monitors so I can actually look over and make sure. So that's great. Okay, good. Thanks, guys, for letting us know that. Oh, goodness. Oh, yeah. So we just had a comment from Jen, who is on our board, and she's also a speech pathologist and has done a lot of adult voice work. And she said one of the most frustrating things is how black and white feeding swallowing can be presented. They passed or they failed, when that is so not how it works.
Exactly. And I think a lot of times, I'm going to speak more on the diagnostic portion of this, because I feel that a lot of times parents don't understand what the steps are in evaluating your child. So you have someone who comes in, whether it's an SLP, an OT, or a PT, who comes to bedside and does what's called a clinical bedside evaluation. So that's where they sort of evaluate the reflexes. They see what the sucking patterns are. If a gag reflex is present, can they swallow? Are they managing their secretions? Are they becoming bradycardic? Are they tachypnic? Are they falling asleep during these things? Those are all important things that will lead up to preparation and whether or not your child is ready to feed. So I think when they call in this team to evaluate, I think that it's really dependent upon the skill set of the clinician coming in to evaluate your child. And I'm sorry, there's no other way to describe this, but we don't have a lot in terms of education at the moment at the graduate level for speech pathologists. So many of these speech pathologists are learning on the job from mentors that may or may not be good at what they do. And so we do these clinical bedside evaluations, and they're not objective. It's a subjective measure. It's whether or not I think your child is doing well, right? It's what I'm feeling when I'm putting my finger in and they're sucking. Do they have suck, swallow, breathe coordination, et cetera? But I think the bigger problem is when we move to those objective studies. So when we go to what we're calling modified barium swallow studies, and when we're going to things like FEES, which are fiber optic endoscopic evaluations of swallow, which are small tubes that are inserted so you can see how they swallow. I think when we start talking about those tests, now we're in a whole nother category, because although they give us good information, they're only as good as the person who's performing the actual test. So many times, and I hear this over and over again. When I'm teaching clinicians at the graduate level, when I'm teaching courses, I hear all the time. I went to my placement and my mentor told me that as soon as the baby started to feed, they started to penetrate or aspirate. So they stopped the study and they failed them. This isn't a pass or fail. A modified barium swallow study is supposed to be used, or what it was intended to be used for, was for you to assess how the child was doing, meaning what does their oral phase of their swallow look like? What does the pharyngeal phase of their swallow look like? How do they organize? Do they have a good suck, swallow, breathe coordination, etc.? And if it's not up to par, if they are having difficulties, your job is to figure out how to make it better. It's not to fail them and send them on their way and bring them back in a month or two to see if they got better. Your job is supposed to be, how can we remediate it to make it better, to preserve all of that oral feeding that that child needs? And unfortunately, that's not what's happening in many of the hospitals. So when you talk about this pass or fail, I completely understand it. It's frustrating for parents, but it's equally frustrating for the clinicians who do have the skill set on the outside of this, who are like, this is not a pass or fail. Don't tell me you gave them 3 seconds of a video and this child is now getting a G tube based on what you recommended without doing any other thickening agents, changing the bottle, changing position. It's just unfortunate, but that's the way it is. Mm-hmm. I wish there could be better clinicians, and I'm not saying there isn't. We do have very good skilled clinicians throughout the country, but not all hospitals have those people.
Right. Yeah. I mean, and like so many things that we talk about of improving the NICU experience and the transition of care post-discharge, right. It's a gap of training and looking at how that can get improved.
Right. And I think it has to start, in all of the graduate programs. You see that we're needing more and more in terms of degrees, but it doesn't mean that the education's getting better, and that's unfortunate. I was taught in my undergrad, I was taught, and we were in a medical program, so we were taught by physicians. That's not how it happens now. Many of the speech pathologists, and I'm not sure about the occupational therapy programs, but many of the speech pathology programs are 4 years of, whatever degree they want to study. And then they go and they apply for their master's in speech pathology. And that's not how it was, 20, 30 years ago. You were studying speech pathology. So you had the opportunity to study swallowing, to literally, work through going and seeing these modified barium swallow and working 300 clinical hours of doing this over and over again. So you were good at your craft. And unfortunately, it's just not what's happening.
Mm-hmm. Yeah, that's definitely one of the things to be aware of, with all of our families as they're going through this, and why we try to do and bring experts like yourself on, so that, again, just that awareness and education, it's so right. critical of, to give people that accurate, understanding of what is really going on and what they're with their child and what that potential is for right. the ability to feed.
Well, if you piggyback to that question, if I were to say to you, I'm going to take your child for a modified barium swallow study, and I did it, and you weren't in the room, and I'm going to tell you the results, and it's confirmed by the radiologist, and we say that your child failed, and you don't even know what you're supposed to be asking. You don't know what that means. What does it mean that my child failed? Did he fail just this test? Does he fail for the rest of his life? Does he fail? No one is explaining this to the parents, that this is a moment in time. This is one episode in an amount of a minute or two that we're looking at. And what were the other strategies and things tried so that you could make him, or at least allow him, to participate in some kind of oral feeding? And unfortunately, that's not what's happening. But the more that we educate families now, suppose they are getting these pass fails in the NICU and they're going home discharged with NG or G tubes. This can be the conversation. You'll be more prepared when you go back for that modified barium swallow study to say, I want to make sure that you're trying everything to preserve and keep my child on the least restrictive diet possible orally. I want to see what he can do.
Right. Really, really helpful information. Question coming in from Lisa, one of our parents. How do we, the parents, help change those current practices and advocate for? And Lisa
Thanks, Lisa.
is a powerhouse parent advocate and one of our volunteers. So
Okay.
I'm not surprised.
Well, Lisa, we can have a whole subcommittee on this, because I have been trying for 32 years to change the dynamics of what goes on. And for a while in my small area, my small region in New Jersey, we were doing really well. And unfortunately, as you know, the landscape of healthcare has changed dramatically. And now it's a dollar and cents game. So quite frankly, the best way to try and change this is education. It's the more education, the better. What I mean by that is it's from the top down. So the professionals have to be educated. Doctors have to know why they're ordering these tests, right? They're just in there saying, oh, he's having problems feeding. Let's order a modified barium swallow study. That may not be the case. Your child may not be a candidate for that. You may never, ever had a bottle or a pacifier in his mouth. And now you're going to put him under a radiological study in order to make him fail. It's almost like you're setting them up for failure. So I think when we talk about how do we make this better, the conversation has to be, how do we educate those people who are on the forefront? How do we get better practices in place to make this more unified so our kids can have better outcomes? So they're coming out of the NICU with some sort of preservation of that, the feeding dynamic of something that we can do. And you can go home right away and you can actively work on that as parents. I also feel that, and again, I'm going to get on my soapbox, I'm sorry, but I also feel that, you're discharged from the NICU and no one has given you any information about feeding and swallowing. You go home with your tubes and everybody's like, well, you have to find a feeding specialist. You have to find somebody to work on feeding. What does that mean? I don't know. I don't know why you're not saying, here's a list of things that you could do to be proactive. Work on X, Y, and Z. Work on the swallowing. Put your finger in the mouth. Get his hands or her hands to her mouth. Let her explore her tongue, her lips, everything. We're not doing that. And then you go home and you're sitting there and you're feeding your child and crying because you don't know what you could do to make it better. And you don't know who to reach out to help you to make it better. Or there's an 8-month waiting list for you to get to that person who can help you. So I think, Lisa, unfortunately, the best answer is we have to educate from the top down. And that means from the neonatologist down to the nursing staff, down to the speech pathologists, OTs, and PTs on how we can work as a collaborative team and get these kids moving, get them out of the NICU.
Really important discussion. Let's see here. And Lisa said, let's do it.
I'm on it. Like I got my Choose Hope t-shirt. I'm with you.
Love it. Yeah, and keep the questions coming, you guys. Absolutely. So
I do want to say something if nobody's asking questions.
Yeah, no, you're good. So
Okay. Sorry. I'm going to keep going. I feel like we're pretty light on the audience tonight. So it'll just be me talking. I think what we have to sort of tease out for families too is the difference between feeding and swallowing. Mm-hmm. So the feeding and swallowing are, although they're interrelated, they're two different dynamics, right? Feeding, you're presenting food and someone's eating that food. That's feeding. Swallowing is an anatomical and physiological event, right? It's something that your body should volitionally know what to do with, reflexively know what to do. So when we talk about somebody being a feeding and swallowing specialist or a feeding and swallowing therapist, we have to be very careful about what that means. Mm-hmm. And if anything I can impart is that you need to be aware that there are many therapists, and it doesn't matter what their background is, are taking courses in feeding and promoting themselves as feeding specialists, but they're not swallowing specialists. Does that make sense? So you can feed somebody and not know what effect or what changes are happening on the swallowing. And the swallowing is what is so critical, is making sure that they're safe to be eating. Right. So I think we, as an educator, as a professional, I think the bigger picture is to try and give you the information on how you can interview your therapist, right? The person you've been referred to, whether it's from your pediatrician, your other therapists, Facebook, social media, and somebody's like X, Y, and Z, this person is the best, go to them. But it may not be the best for your child. Their child may be significantly different than what your child is experiencing. So I always say this when I'm lecturing to parent groups is that we do more research on appliances and cars than we do interviewing or researching the people who are supposed to be making the biggest impact on your children. So I think where it comes down to is that it's our responsibility, not only as the professional to be transparent and let you know what our skill set is, but your job as the parent is to interview them thoroughly. You need to find out what is their skill set. What are they able to do? How many children have they treated with HIE or cerebral palsy? How many children do they have in their caseload who are aspirating? What are the types or methods or models that they use in order to, rehabilitate that or habilitate the swallow? What are their, protocols? How are they determining progress? You have the right to ask all of these things. And if the therapist is sort of reluctant or defensive, then that's not the right choice, right? You need somebody who's going to be part of your team and who's going to advocate for you and your child. So I think when we're talking about how we get to the therapist themselves, it's the responsibility of the parent to be the interviewer. Make sure that you get the information you need and make sure that that team member is the right person for your child.
Very, very helpful. We're seeing a lot of yes, agree.
From all three of them.
we've got 21 people watching.
All right, good. Yay.
But yeah, just a comment from one of our parents, Jennifer, a huge frustration is how my daughter can easily be written off once people knows that she has a brain injury. Competent clinicians have no problem with second opinions typically. And, just people also reiterating how hard it is to find a good swallowing and feeding therapist.
And I feel for you. Every day I'm fighting the fight, as I'm getting sort of lumped in to now a whole new substrate of professionals who've taken weekend courses, right? So they're taking these approaches where, let's just throw it out there, like the SOS approach to feeding. And I'm sure you're all going to hear about this approach because it's marketed heavily. But it may not be, it's not the right fit for your children. The SOS approach, like when you're taking one sort of marketed course, and that is what you're building your caseload on, that's not the right movement. What we need to do is be educated in everything and pull from your toolbox. I have so many certifications. I've taken everything that's out on the market. I never say that I do this X, Y, and Z type of therapy because I'm pulling from everything. Not all of these programs fit one child, and not all of these sort of educational platforms understand what it is like to have somebody with a brain injury sitting in front of you. And those vary in degrees. So you can't have one program and you can have a child who's mildly affected and you have one who's severely affected. How does that fit into their domain? It doesn't. So we have to be very careful about that. I think there was a point I wanted to make about that too. Sorry. I lost my train of thought.
You're fine. You can always come back to it.
Okay, we'll come back to it. Sorry. This is what happens when I start rattling. I'm on my soapbox. I can't seem to get off of it right now.
It's so great. Lisa is saying it may be time for you to write some protocols. So there you go.
Thanks. She's giving me a lot of work to do. Now I'm having a committee. I'm going to be writing protocols. No, and I think that's true. I think that we do need to have, sort of camaraderie and get people from across the country to figure out what's going to be the best. Everybody's talking about, and this is no disrespect to physicians, to parents, but everybody's talking about evidence-based practice, right? And it's a big keyword. Everybody's like, oh, you're doing this. Is it evidence-based? Well, quite frankly, I'm going to be honest with you. If it's not evidence-based, but it's helping your child, there's my evidence, right? So if he's the first kid that I tried kinesiotaping his nose to get more airflow, and it's working to get him to learn how to suck, swallow, breathe, and there's no protocol for that, I'm still going to use it. It's that I have to worry about. Doing nothing is not okay. Doing something and making it better is where we want to be. And I'm so afraid that we're all into this whole henhouse of evidence-based practice. It does serve its purpose. We don't want people, selling essential oils and putting it under their nose, telling them it's going to make their swallowing better. And it's no disrespect to the essential oil group. I'm just saying that it's, we have to be careful, but we also have to think critically when we have these children in front of us. We have to be able to look at this child and say, this is what they need. There's where the problem lies. Let's move forward and kind of focus in on that. And I feel like many of the clinicians around the country don't look at it from that perspective.
Mm-hmm. Well, I think when you're looking at, different groups coming together, and that's one of the things that I'm really excited about as we were talking with organizations like the Newborn Brain Society. And, just like I said, there were so many questions that came in today of the webinar earlier about feeding, from all around the world. And it's clearly an unmet need for the clinicians, and it's like, what is that work group going to become? So that's, there's a lot of exciting things from that side of, collaboration and looking at these things and outside of these silos that exist. So I'm really encouraged by, conversations like that are had, but, in the meantime, kids need what they need. Right. So
exactly. I think I remembered my point before when you were talking about, I don't know if it was Lisa or somebody else, when you said that they write off your child because they know that they have a brain injury. And that's very true. And that's one of the things that if anybody has ever gone through our program or is, investigated it, one of the things we never ask you for are previous records for feeding and swallowing. And we never ask you about the child's diagnosis. If you tell us that they're HIE, that's fine. But when you give somebody that information, I feel that they're already predetermined on what their skills are going to be. And for us, we have to look at the child that's in front of us. And we need to see what their skills are and how they're going to benefit from what we're able to give them. So many times we'll look at, it's not just the HIE community. We have autism as another diagnosis, right? And the minute we hear autism and they're coming in for feeding, you already build this sort of mental block, like what's going to happen and you don't. So a lot of times, I feel like clinicians will see the diagnosis of CP and already they know, they're going to be drooling, they're going to be tongue thrusting, they're going to have open mouth posture, and your child may not have any of those things, but they've already built up the scenario in their head. And that's where it becomes very complicated to try and stop that sort of, pre-diagnosis, predetermined skill set.
Absolutely. So we have a question from Crystal that said, I know you do intensive feeding therapy for some kids who come to you. Do you recommend that over a slower once or twice a week approach?
So we do have children that come in, once, twice, 3 times a week. What we're looking at is the difference between the ability to do it intensively and sort of laying those neural pathways quicker. We're finding, just like everyone else who is on this sort of investigative trial approaches to neuroplasticity, we know that if we do something repetitive time and time again over a short durational burst, that we get better outcomes. So although we don't discourage anybody from seeking treatment, even if it is only 1 to 2 times a week, at least it's something. And part of our sort of program that we like to facilitate here is educate the parents. You're in with us the entire time. So many places don't allow the parents to be in the room, or they're in the room feeding the child while somebody is sort of narrating what to do from the outside. That's not how we approach it. So we want you in there anybody and everybody, because we need to know you may not be the person feeding, you may be the mom, but if you're working and the nanny's taking care of them or grandma's taking care of them, they need to know what they're supposed to do. So it is all about education, making sure you know what to do, what the next step is going to be, and how you're going to tackle that. And the other thing, which is unique to us, is that we give you our cell phone number so you can text us all the time. We're in constant communication, and that's one of the foundations I built this practice on, was making sure that our parents had adequate access to us at all times. Mm-hmm. You can't be leaving here in the middle of the day and then dinner time comes and your child's choking or not responding well, and you can't get in touch with us because you have to wait until 9 o'clock tomorrow morning. That doesn't fare well. So we make sure, and that's what we pride ourselves on, that we're able to communicate with everybody, even after you're done with the programs here.
Yeah, that's so important. And that's one of the things, especially, we can't escape the topic of COVID-19 right now, that we are, encouraging families, like, having access to their, whether it's something like feeding and swallowing or, suspected seizures, and, having that access of, what is that, and advocating to find out what that needs to be. So when you're in a situation where, a therapy or, something that you're trying at home isn't going well, and you need to use that teaching moment or, kind of invest in, coach, exactly.
Right.
How can you get that, and that's such a wonderful way of, building those relationships and helping kids thrive, from and really maximize the therapy and the interventions that are given.
Yeah, we have to look at it that even if we did intensive therapy, we do it 2 to 3 times a day, right? So each session is an hour. So 3 hours a day. All right. There's 24 hours in the day. So even those 3 hours, yes, they're getting the intensive treatment. We're training you, we're teaching you, we're habituating new patterns for the children. We're sort of laying those foundational skills. But you're with them the other 21 hours. So if I don't educate you on what to do and I don't help you through it, then it's kind of like we're starting all over the next day or the next week, because it's moments that we've lost, that we could have intervened and sort of helped you through it so that we can be on that next level when you come in the following week or the next day.
Right. Absolutely. We have another question, and then I'll ask you about where you're at in your list of things. Any words of advice in regards to a tongue tie?
That's my hot button topic right now. So that's what I seem to be lecturing on the most lately, has been tongue tie. So there are many people throwing their hats in this ring. And I'm just going to say this as a blanket statement. Yes, tongue tie is an actual issue, can be an issue in feeding and swallowing and in speech. What my fear is that clinicians are taking these weekend courses again, and they're looking at, oh yeah, I can see that your tongue doesn't reach the palate, so you have a tongue tie, you need to go get this remediated. So I'm going to explain to you what this all means in a nutshell. When you're doing, or when you're assessing for a tether, because that's exactly what it is. It's a fibrous tissue growth, whether it's underneath the tongue, whether it's to the cheeks, whether it's your upper lip, your lower lip. You can have tethers in all of these spots. And we like to call them tethers because they're not necessarily ties. So when we talk about tethers, we talk about what impact do these tethers have on the function of the mouth. Not that the fact that they're there, but the fact that the impactful fact of what they're doing to sort of prohibit or inhibit the proper movements for feeding, swallowing, and speech, right? So we need to do a thorough assessment. And there's only one way of assessing, and that is to see what the function is. So many times we have parents coming in and saying, oh, I took my child to the pediatrician. I told him you said he had a tongue tie. He told him to stick out his tongue and said, nope, he doesn't have a tongue tie. Well, there's different types of tongue ties. There's what we call your anterior tie, which is the tie that's in the front. That's the one where children have the most difficulty elevating their tongue. And most often it's usually cut, whether it's in the NICU or in the newborn nursery or in the pediatrician's office or an ENT. And they take a scissor and they cut it. The more problematic one comes in what we call the posterior tongue tie, which is further back. And that is where the tongue is restricted or sort of tethered to the floor of the mouth. So it's unable to reach the palate. Why is that important? Well, you need to be able to have that pressure, that movement against the palate so that you can form the palate the way that it needs to be over time. So those junctures fuse correctly. You need that in order to express the breasts or the nipple. You need it for adequate sucking and swallowing. When we see children who have tethers, we try to do it on what we call a functional scale. So how impactful is it? Is the child having difficulty gaining weight? Are they gassy? Are they swallowing too much air? Are they fatiguing and tiring out? All of these questions come into play. So it's not so easy to just say they have a tether, because quite frankly, I have one and I could show you it. It would be disgusting to show you right now, but I actually have a tether, but I'm functional, right? I can eat, I can speak well, my palate is fine, I breathe fine, I don't have tension, I'm good. So you can have it, you can have these restrictions and they're not impactful. But when they become impactful, that's when we need to do something to remediate it. So a lot of times, especially in the HIE community and a lot of my other, diagnoses, the doctors will say, we're not going to do that. That's the least of his problems. We're not going to cut that. We're not going to laser that. And my thought is, if we laser it, then I'm going to get better range of motion of the tongue. I'm going to habituate better feeding and swallowing and better placement of the tongue so that they might be able to close their mouth and breathe through their nose. And I think, we have to, as a society, start to change on treating our special needs population the same as our typical population. So just because they have some underlying condition doesn't mean that they're not, they're not a subject that can't get released for this. And so a lot of my kids that are coming in, I'm starting to see more and more with this HIE population in particular, is that they're having a lot of these tethers. And so we're getting them released and we're starting the impactful swallowing and feeding therapy right away to habituate those new movements as quick as we can. Sorry, that was really convoluted.
No, I think it's really interesting. And this comes up all the time in our community, all the time. People say, oh, my kid has been, honestly, questions like, who's had a tongue tie? Who's had a, lip tie? What difference has it made? And that's something that continually comes up. So having this, to hear from you again, it helps people understand and be educated as they move forward. So,
I think you have to also, it goes back to getting the right person on your team, because it's not just about releasing. A lot of kids need to have therapy before they get the release done, because you need to be in their mouth to make sure that this doesn't reattach. There's exercises that are required that you need to do post-operatively so that this doesn't reattach and they have to go through the procedure all over again. So we have to avoid scar tissue. We have to avoid reattachment. And that comes with somebody who has the skill set to identify who is a candidate right away and who needs pre-therapy before they can get that done. And then there's post-therapy that has to focus on getting that the movement or the patterns of the tongue, of the lips, the way that they're supposed to be functioning. And so if you don't have somebody who understands that, just getting it released is going to do nothing for your child. You need somebody who's going to sort of habilitate that into the position or the function that it needs to be.
So helpful to understand. Absolutely. Thank you for that. And people are saying amen all over the place on that one. So.
Well, I'm glad.
We do have a couple more questions coming in, and then we'll get some final thoughts from you and wrap it up for the night. But one, Natalie says, my girl passed a swallow study. I feed her by mouth every day during her tube feeding. Any advice or approach to help her want to eat by mouth? She does not want to.
So that's a great question. And it's a question I get every day. And I see it every day when I have patients coming in. who are on these tube feedings. So I guess my question back to this particular person is, what is their feeding schedule like? So if we're eating every 3 hours and we're having X amount of mLs, we're never giving them the opportunity to understand hunger or satiety, right? The ability to feel that drive to want to eat and the knowing that we're full. So if we're constantly on this schedule of we're having 180 ml over an hour and a half every 3 hours, we're not even getting that digestion kicking in before we're on the next feed and trying to feed them by mouth. So I know this is always a bone of contention between feeding therapists and nutritionists. So I apologize for anybody who's in the nutritional field right now, but many times we sort of go around them and talk to the physicians and say, we need to reduce the feeding schedule. We need to, if they're being fed overnight, can we make them into bolus feeds? Because getting a teardrop of fluid every 5 minutes is not helping anybody. They're never in rest, right? If they're feeding and digesting all night long, and then you wake them up and you put them in the chair or you hold them in your arms to feed them for breakfast, they're not going to want to eat. It's like us eating a full Thanksgiving meal and then saying 15 minutes later, okay, here's your Thanksgiving meal. It's impossible. So we have to do better in sort of getting the volume and the time reduced so that we can sort of precipitate or manifest that hunger cycle. And that's where I find a lot of the kids, it's not an overnight thing. A lot of people will say, oh, we did it for 12 hours. He wasn't any hungrier. Well, it takes 8 to 10 days to change human behavior, right? And it takes 8 to 10 days in order for your body to adjust biologically to feel these things. So we need to do better in supporting this. But one of the things that you can talk to your nutritionist about is if it is a prolonged feeding, meaning that if it's greater than 30 minutes, is there a way that you can reduce it to 30 minutes? If it's a volume issue, is there any way that we can change the volume and add more calories? So we're not having such a high volume, we're having smaller volumes, but the same amount of calorie impact, so we're not losing weight. It's difficult because as that feed is going, they're already digesting from the stomach down, right? So digestion starts at the mouth. So if we're not in this phase of eating orally, they're already digesting, their body's already in this motion, in this movement, and then we put in the bottle for them to eat. And now we kind of have this, where are we at? You know, what is the brain telling the body what to do? Am I sucking and it's filling up? Because it's filling up all by itself. So it's kind of this battle between the two. What can we do to make it better? So if we can eliminate, let's say, one of the feeds and see how she does without it. I mean, it's one of the things that you could try, but I would definitely talk to your nutritionist and your team. You know, again, I can't offer medical advice on here, but one of the things that we would do is absolutely get in touch with your GI doctor or your pediatrician and say, here's the plan. We want to see if we can, she has the skills, she's able to do it. It's just the hunger drive is not there for her to want to eat.
Mm-hmm. That's super, super helpful because again, that is a question that comes up all the time when, you know, these kids are like, they do have some, you know, some oral skills, but they're, you know, balancing like, again, topping off with a tube or doing, you know, all of these different things. And it's, you know, it's overwhelming for families again, to not know what that trajectory is and what those next steps and what you're working towards.
And I think people get frustrated and give up a lot sooner too, because they're like, it's not working. You know, it's not immediate enough because nobody's explained to you what the biological process is, right? So if we don't know whether or not they're hungry, there's no hunger cue. We're all on this sort of time, these parameters of time, and this element of X amount of mLs to get them to be on this growth curve, to get them to do this. If they weren't tube fed, if they didn't have a brain injury, would we still be under the same microscopes? Would we still be held to the same accountability for nutrition, right? Or would we allow the child's body to just tell them what they need to do? We never give our kids a chance, you know, and that's where, you know, again, another conversation we can have with a nutritionist and a dietitian and a neonatologist, or a GI doctor. But for right now, I think that, if she can talk to her team, if you can talk to your team and see if you can at least modify it so that you can get some sort of success since she can orally feed, that would be your best option.
That's great. Thank you for talking through that. I think that was our last question. And so any final thoughts, Nancy, on
Listen, this is a huge topic. And as I can talk on and on and on about it. You just give me a topic and I'll keep going. But I think, the takeaway from here is that, again, it's all empowering parents. It's not being afraid to step up and advocate for your children. You're doing a great job in terms of all of their medical and making sure that they're cared for and they're doing well. And that's great. And it's admirable, but we got to take it one step further. And I feel like we look at PT and you see them get walkers and they're walking, and you do OT and we see them doing activities with their hands. But then we talk about feeding and swallowing or even speech, let's say, and we're kind of like, that's not such a high priority, nor is it a big goal for us. We were told that he's not going to talk or that he's never going to eat by mouth. Nobody has a crystal ball. Nobody can tell you that your child can't do something. We know that medicine is changing every day, and so is research. And we know that our methods of delivery for therapy are changing, hence the intensive programs. That was something that was never on my radar 20 years ago. But now I see the difference in these kids. I see the impact this has from kids who are coming in who are barely eating, and now they're chewing and they're eating pizza and they're eating these fantastic things and doing well. And parents are going home and saying, we were able to do it. We were able to continue this. That's where we need to be. And my wish is that it's for everybody. Right. And if they are aspirating, let's figure out why they're aspirating. Don't tell me because it's a brain injury. Why are they aspirating? Mm-hmm. Tell me why. And then we can fix it, or we can remediate it, or we could do something to make it better. And that's what I really want to impart with everybody. Just stick to your guns.
Well, you are an incredible advocate and partner. I forgot to mention at the beginning that you have joined our medical advisory board, and we want to thank you so much for all of your support and your advocacy for our kids and our families, and partnership and imparting and educating our families as we go. And we're getting a ton of people saying, thank you for believing in our kids. Thank you, thank you, thank you. So
I do believe in your kids.
I know.
I do. And I think that's a bigger thing too, is that you need to find people who, first of all, respect your kids. And I feel that it's more of, it's on the therapist. It's their job to make sure that you have this mutual respect for one another. Because if I can't get the children to know that I'm somebody who's safe, that I'm somebody who's there to rally for them, I think it's all lost. I think if you don't get that relationship with your feeding therapist or your speech therapist, we have to find new people. You have to find new people. They're out there.
Absolutely. Well, thank you again so much for your time and your enthusiasm and your knowledge share. It is absolutely vital for our community, and we hope to do this again.
Yes.
It's so great. And again, thank you for everything tonight, and thank you everyone who's joined us and asked great questions and followed along. We try to do these, and we'll be doing more of these live events with our Q&As with our experts. And so look for more of those coming up. All right.
I just want to mention one more thing. I'm sorry. And you can follow us on our Facebook page. There's videos, there's photos, there's stories, there's a ton of information in terms of, patients and how well they've done. And it doesn't have to just be here. If we can help guide you to the right people, I will do my best to find those people for you. I think that is part of our goal, right? For HIE and our organization is to get people in the right direction. So thank you, everybody.
Thanks, Nancy. And thanks everyone for joining. Have a great night.
Stay safe, stay well.
All right. Take care.
Bye-bye.
Bye.